I would like to talk to you about congenital thoracic disease as it manifests in the adult. So we typically think of congenital thoracic disease as a pediatric diagnosis, but most of the entities that can be diagnosed in the pediatric population can slip through undetected into adulthood. And when they're encountered in the adult patient, they can be sometimes confused with more sinister pathology, including malignancy. It's also important to know that when you encounter a lesion and you're diagnosing it as a congenital disease, to really understand what are the key features that you need to describe, which will be important in the clinical and surgical management of the patient. And also to know which, if any, additional imaging modality might be useful. So what I'll take you through is some cases that we've encountered at our institution. The first case is a 69-year-old man with fever and cough who was non-responsive to antibiotics. He had been treated for pneumonia, and this was a radiograph that was obtained several weeks after his treatment for routine community-acquired pneumonia. It demonstrates an area of airspace consolidation in keeping with pneumonia in the posterior segment of his right upper lobe. But if you look more closely, you see that there's a rounded mass in the region of the right hilum, fairly well circumscribed and somewhat better appreciated even on the lateral radiograph. So like all good chest radiologists, we went through the stacks to see if he might have a prior examination for comparison, and he did from 4 months ago. And at that time, he obviously didn't have the pneumonia, but he had this well-circumscribed mass in the region of the right hilum. So in continuing our exploration, at that time of the prior exam, he had had a CT, and he had actually had a CT 4 years prior. They both demonstrate the same finding of a homogeneous, well-defined lesion in the right low hilar region that was approximately 15 Hounsfield units in density, and between the post-contrast study and the non-contrast study had no internal enhancement. So these findings were all in keeping with a bronchogenic cyst. It had grown slightly in size over time, but again, no enhancement and had fluid attenuation. So this is one of the complications that you may encounter in a patient who has a bronchogenic cyst, is that because of mass effect, it can lead to post-obstructive symptoms. This patient actually underwent bronchoscopy where they did endobronchial aspiration of the cyst to relieve the mass effect, and this was a post-procedural CT demonstrating the pneumonia and an air fluid level, and then follow-up treatment after antibiotics demonstrated that the bronchogenic cyst had decreased in size and the pneumonia had now resolved. So a bronchogenic cyst results from abnormal budding from the tracheobronchial tree. Bronchogenic cyst and esophageal duplication cyst are really differentiated pathologically in that bronchogenic cysts have respiratory epithelium and elements of cartilage for their diagnosis. These are usually subcarinal or paratracheal in location, though a small percentage can actually be intrapulmonary. The majority of these lesions we encounter in the adult are asymptomatic, and if they are asymptomatic, there's really no reason to do anything for them. But sometimes, as in this case, they can have mass effect, or they can potentially even become superinfected, and if that's the case, may demonstrate REM enhancement or even air fluid levels related to fistulous communication with either the airway or the gastrointestinal tract. So at the bottom of the screen, you have 3 patients, 2 of which have bronchogenic cysts. The patient at the bottom left has a similar appearing lesion to the patient I had just shown you, homogeneous, low attenuation, measured about 20 to 25 Hounsfield units internally. We know that sometimes bronchogenic cysts can be filled with proteinaceous fluid or even hemorrhagic fluid, which can raise their density and make it easy to confuse these with lymphadenopathy or soft tissue masses. This patient was fortunate in that he had prior imaging, and we were able to document stability of this lesion over 3 to 4 years, and this was in keeping with a bronchogenic cyst. The patient in the middle had a nodule detected on a chest radiograph. Again, similar lesion, low attenuation, actually measured fluid, and we had a pre- and post-contrast study that demonstrated no internal enhancement. So this was in keeping with a bronchogenic cyst, although there was some concern of necrotic tumor or potentially mucus impacted within a bronchus. This patient actually went on to surgery and had resection of the lesion, and the pathology was that of a bronchogenic cyst. About 10% of these lesions can actually occur within the lung themselves. The patient on your right, though, had a similar appearing lesion, but measured approximately 30 Hounsfield units, but this was a low-grade follicular lymphoma, so it can be very tricky to differentiate them if it's more than water and attenuation. And if there's any concern or any doubt, I would strongly encourage you to consider using MR, because MR has the benefit that if a lesion is proteinaceous or hemorrhagic, it will maintain its T2 hyperintensity. And the more heavily T2 weighted your sequence, the brighter the lesion will become. If there's any doubt after looking at the T2 weighted sequences, you can do post-contrast subtraction imaging to look for any internal enhancement, which a bronchogenic cyst shouldn't normally have. Lymphoma or lymphadenopathy will be more of an intermediately elevated T2 signal intensity and obviously show internal enhancement. If the patient has a strong suspicion of bronchogenic cyst to start with, I would encourage you to think of MR as a primary imaging modality as well for investigation. Next patient is a 22-year-old woman with shortness of breath and left-sided chest pain. I was actually in the emergency room the day the patient came in. They brought me an outside chest radiograph that much resembled this topogram, and they said, "Chris, this patient has chest pain, and she's coming to the ED, but she's telling us she has a history of congenital lung disease. She doesn't know what the lung disease is. She can't tell us. So what do you think?" And I said, "Well, it looks like your patient has a tension pneumothorax. There's a large area of lucency, mediastinal shift, well-defined pleural line." And there was some consternation over the part of the emergency room and the surgeons. I don't know what that says about my ability to convince them that because of this history of congenital lung disease, could they be dealing with a congenital abnormality? So the patient was hemodynamically stable at the time, and I said, well, let's just quickly put her on the CT table, and I can prove that it is a pneumothorax. We'll just do a quick non-contrast study. And it confirmed that there was a pneumothorax. But interestingly, you notice that in the left upper lobe, despite there being a large pneumothorax, the lung is not completely collapsed. It's the same attenuation as the normally inflated right lung, but you have this tubular opacity in the left upper lobe. Patient had chest tube placed and subsequently had a post-contrast CT obtained or performed, and it demonstrates this non-enhancing branching tubular opacity surrounded by a focal area of air trapping within the left upper lobe. So these findings were in keeping with an area of bronchial atresia in the lung, which would go along with the patient's reported congenital lung disease. This patient actually underwent resection of this portion of the lung. I think there was some concern as to whether it had played a role in her pneumothorax, although if you look back at the non-contrast CT, you'll notice the bronchial atresia remain inflated, so it probably was an incidental finding in relation to her pneumothorax. But this is the pathologic specimen, and this is the dilated distal bronchus, distal to the area of atresia, with the mucus plug having been removed. So bronchial atresia results from atresia of a central bronchus. Usually it's at the segmental or subsegmental level, and it's thought to result from a vascular insult during development. The distal airways form normally, and as a result of that, they become impacted with mucus, giving the characteristic branching mucocele or bronchocele. There's regional air trapping beyond because there is collateral airflow into this region that can escape through the bronchus. The majority of the time that we encounter these lesions, they are asymptomatic, incidentally detected on studies done for other reasons, so they're do not touch lesions, and it's fairly rare for them to be symptomatic. At the bottom of the screen, there are 3 patients, 2 of which have bronchial atresia, but 1 of which does not. Patient on the bottom left presented with a PE protocol CT to our emergency room. You see a branching, non-enhancing opacity in the right lower lobe, which if you're just looking at the PE windows, you might think, could that be an occlusive embolus in the right lower lobe? But if you look at the lung windows, it demonstrates that classic focal area of air trapping surrounding it, and this was a case of classic bronchial atresia. Patient on the far right had a branching nodular opacity that was initially detected on the chest radiograph, which led to the CT. This was a non-enhancing area, again, a focal area of air trapping in the right upper lobe, and this was the mucocele with focal air trapping in keeping with bronchial atresia. The patient in the middle has an area of lobar hyperinflation, or hyperlucency, air trapping in the left lower lobe, but you notice you don't see the classic bronchocele in this case. If you look closely, centrally, there's a small enhancing nodule within the left lower lobe bronchus, and that's because this was a case of carcinoid. So in the adult, when you're entertaining the diagnosis of bronchial atresia, one thing you must exclude is a central obstructing lesion, so I encourage you to look centrally. This is that patient just blown up so that you can see it more easily. Central enhancing nodule from carcinoid with focal air trapping and air trapping in the left lower lobe. Sometimes these lesions can actually infiltrate the airway, as in this different patient on the right, where you see the tumor actually infiltrating a lingular bronchus, and it actually mimics the mucocele in relation to, as well as having an area of focal air trapping within the lingula. So it's always important to look centrally to exclude a central obstructing lesion when you're entertaining the diagnosis of bronchial atresia. The next case is a 35-year-old man who presented with shortness of breath that had been progressive over several years. Initial chest radiograph demonstrates hyperlucency in the left upper lobe. You can see some compressive atelectasis in the left lower lobe and some mediastinal shift rightward. Certainly the first thing you want to make sure is you're not walking over a tension pneumo, as I had shown you earlier, but we could make out lung markings in this region. The other thing is maybe you were dealing with a large bleb or bulla, actually a large bulla within the left upper lobe. Patient went on to cross-sectional imaging, and at cross-sectional CT you see that there is hyperexpansion of the left upper lobe. We don't see bullous change, but we see mass effect with compression on the left lower lobe, as well as mediastinal shift rightward. This patient did have a component of a severe pectus deformity as well that accentuated that to some degree. If you saw this case in a child that was 2 or 3 years old, I think it would be no problem, you would have no problem making the diagnosis that this was a case of congenital lobar hyperinflation. If you do some coronal minimum intensity projection images, which accentuate the area of air trapping and hyperexpansion, you can see the left upper lobe and again the mass effect and mediastinal shift. This patient underwent a VQ scan demonstrating the small airways disease and the actual obstruction, within the left upper lobe. You can see there's delayed wash-in and retention of the agent on ventilation portion of the scan. Congenital lobar hyperinflation was formerly known as congenital lobar emphysema, but that's a misnomer because emphysema implies interstitial destruction in the lung, which is not present at histology and pathology of these patients. They simply have hyperexpansion of the airways themselves, so it is a true hyperinflation, not emphysema. Can result from intrinsic causes of webs or malacia within the airway themselves, or extrinsic mass effect. Congenital lobar hyperinflation has been associated with bronchogenic cysts within the chest, presumably because of mass effect, like I had shown you in the first case, and possibly from aberrant anomalous arteries or extrinsic compression by vasculature as well. The left upper lobe is the most commonly reported location. These are 2 different patients at the bottom of the screen. Again, the patient on the left demonstrates the hyperlucency and air trapping within the left upper lobe with mediastinal shift rightward, indicative of mass effect. The patient at the bottom right has hyperlucency that affects not only the left lower lobe, but a portion of the lingula as well. So the difference between the 2 cases is obviously the patient at the bottom right has a smaller hemithorax to start with, and that's because this patient has Swyer-James or an acquired bronchiolitis obliterans. The difference between the 2 is mass effect, and these 2 entities are sometimes, there is clinical difficulty in differentiating the 2. Swyer-James syndrome is presumably due to an infection that occurs during childhood, sometimes viral, sometimes bacterial. And on inhalation-exhalation sequences, the smaller hemithorax will demonstrate air trapping, similar to what congenital lobar hyperinflation will. In this patient, you also notice there's peribronchial thickening, which would go along with the sequela of the patient's prior infectious insult. Different patient on the right demonstrates the focal area of air trapping within the left lower lobe. And if you notice on the soft tissue windows, there's also decreased vasculature in this region, again going along with this patient's history of severe pneumonia in this location in the past and a resultant acquired obliterative bronchiolitis. So the key difference is while they'll both demonstrate exhalational air trapping, congenital lobar hyperinflation exerts mass effect. The next case is an 18-year-old woman with asthma, and she underwent CT examination, I believe initially looking for tracheomalacia because she had pretty severe unresponsive asthma. And on the CT examination, you see that there's this conglomeration of thin wall cysts within the apical and posterior segments of the right upper lobe. Certainly diagnostic possibilities initially you could think of would be post-infectious or maybe post-traumatic pneumatoceles, potentially congenital lung abnormalities like cystic sequestrations. But I think if you saw this case in a young patient, a 2 or 3-year-old, you would have no problems of thinking of a congenital pulmonary airway malformation, which is what this turned out to be. This patient had prior imaging studies from 3 and 4 years ago that demonstrated stability over time of this lesion. So congenital pulmonary airway malformations were formerly known as cystic adenomatoid malformations. We no longer use that terminology because it doesn't reflect the underlying histology. in that the majority of these lesions, or the several of these lesions are not cystic, and only one of the lesions is actually adenomatoid. They result from disorganized lung tissue with bronchiolar hyperproliferation, and they will have airway communication, but usually they have normal pulmonary arterial supply and pulmonary venous drainage. There's a lot of overlap between congenital pulmonary airway malformations, bronchial atresia, and sequestration, both radiographically and histologically, to the point it can be difficult for the pathologist to actually differentiate the three entities if he's just looking at the slide. These are three different cases at the bottom of the screen, two of which demonstrate congenital pulmonary airway malformations. The patient on the bottom left, again demonstrating this conglomeration of cystic air spaces focally within the left lung. I don't know if it projects very well, but the patient in the middle has a focal cystic lesion that has multiple fine internal septations, and these would both be good appearances for congenital pulmonary airway malformations, and they had no reported history of prior insult or infection in these regions. Patient at the bottom right has two cystic air spaces with a little bit of fluid within them. Of course, it's a little bit unfair just to show you one image, but this was a case of bronchiectasis, and it was varicoid bronchiectasis from a prior infection within the left lower lobe, and it's one of the things you think of when you encounter cysts in the lungs. Could you be dealing with an airway abnormality? So I think you're all familiar with the Stocker classification system. It was expanded back in 2003. It goes from type 0 to type 4 lesions, which varies depending on the level at which the bronchiolar hyperproliferation occurs, from central to more peripheral in location. Most of the type 1 and type 3 lesions, which are the more common lesions encountered, are detected in childhood because they're large cysts or either solid lesions that come to clinical attention. In our clinical experience, most of the cases of congenital pulmonary airway malformation that we found in adults have actually been type 2 lesions, which is a conglomeration, some of the cases that I've shown you, of multiple small cysts. There is some reported increase or slight risk of malignancy in some of these lesions. Type 1 lesions do have mucogenic epithelium, and there have been reports of mucinous adenocarcinomas that have developed in them, and that's why some of these patients have continued to be followed, but it's a very, very low risk of malignant transformation. Our next patient may be the most famous patient at the Society of Thoracic Radiology this year, if you've been participating in the unknown cases earlier today. This is an 18-year-old woman with shortness of breath and chest pain. I was actually in the emergency room when she came in as a resident. So we read her chest radiograph. There was an area of airspace consolidation in the left lower lobe that we saw. She had a fever and a white count, so we read it as a pneumonia. Our ER, as always, is very obsessed with pulmonary emboli, so they were concerned she could have a PE in addition to pneumonia. So we did a PE protocol on her, and I guess that was to our benefit in this case. You see a large heterogeneous soft tissue mass occupying the majority of the left lower lobe, heterogeneous with some areas of cystic or necrotic areas within it. But before we jump down our path of could we be dealing with sarcoma, could we be dealing with an inflammatory pseudotumor, we notice the key distinguishing feature here, which there's a large feeding systemic vessel arising from the descending thoracic aorta, which is nicely displayed on this coronal maximum intensity projection image, feeding this large lesion. And you can actually appreciate that the pulmonary venous return is to the left atrium through the left inferior pulmonary vein. These findings were in keeping with an intralobar sequestration, and this patient had a history, once it was ferreted out a little more, of recurrent pneumonias in this location. So this is one of the more common presentations of patients with intralobar sequestration to present with recurrent pneumonias. It's an area of non-functioning tissue which is sequestered from the tracheobronchial tree. The hallmark feature is systemic arterial supply. Usually it comes from the descending thoracic aorta, though it can arise from any systemic source, intercostal arteries, internal mammary arteries, or even the abdominal aorta. And there's some debate as to whether these represent true congenital lesions or acquired lesions. In the past, we thought they were acquired lesions because most of them came to attention in later childhood or early adulthood as a result of recurrent infections. They don't have their own separate pleural covering, which is presumed to allow them to more easily become infected. And at that point in time, we hadn't detected many of them on fetal ultrasonography to suggest that they would be congenital. But with increasing use of fetal ultrasound, we know that these have been detected, and some of them are actually true congenital lesions and share a lot of histologic overlap with both bronchial atresia and congenital pulmonary airway malformations. So some of these are truly congenital abnormalities. This is a patient that just shows there's a lot of variability in the appearance of sequestrations, from the solid lesion I had shown you before to this predominantly cystic lesion that had a feeding artery coming off the celiac axis, crossing the diaphragm. This had been superinfected with a mycetoma and underwent surgical resection. These are 4 different patients, 3 of which have sequestrations. Patient at the top right had prostate cancer as a new diagnosis, had a necrotic nodule seen in the left lower lobe, and this was actually read as a metastasis or a primary lung malignancy. But if you look closely, there's a feeding artery coming off the descending thoracic aorta to this region, intralobar sequestration. Patient at the bottom left demonstrates a focal area of air trapping, very much resembles an area of bronchial atresia, again demonstrating the fact that there's a lot of both radiographic and histologic overlap, but had a systemic feeding artery to this region. Patient at the top left, however, had some small vessels around this lesion, but this was a necrotic lung adenocarcinoma. Patient at the bottom right was a patient who had had recurrent severe pneumonias in the lingula and had developed collateral blood supply to this nidus from both phrenic arteries and intercostal arteries, probably an acquired intralobar sequestration. The next case is a 21-year-old woman with chest pain. She presented with pleuritic right-sided chest pain and has this right paravertebral mass with a small right pleural effusion. So neurogenic tumors were included in the differential diagnosis, possibly extramedullary hematopoiesis, lymphoma. The disc space looked normal, so it wasn't thought it was a disc space abnormality. This was an outside hospital study. If you look closely, though, there's a tiny vessel arising off the descending thoracic aorta that's very easy to walk over. The nice thing in this case was that there was an MR performed a couple of weeks later where the effusion had become larger, and you can now see this area floating within the pleural space. This was not a paravertebral abnormality at all. This was actually an extralobar sequestration separate from the right lower lobe, enveloped by its own pleural covering and floating within the pleural effusion. At surgery, this had torsed within the pleural space and was the cause of the patient's pleuritic chest pain. So extralobar sequestrations are differentiated from intralobar by their separate pleural covering, which can be difficult to differentiate at radiology without the finding of a pleural effusion that it's floating in. And they always have a systemic artery. Usually they have systemic venous return. We rarely encounter them in the adult. This is a pediatric example, much larger lesion. Sometimes they're associated with diaphragmatic defects, but pretty rare to encounter in the adult. The last case I'll show you is a 45-year-old woman with asthma and abdominal pain. Demonstrates areas of hyperinflation, hyperlucency, mucoid impaction, as well as conglomeration of cysts. Features of both bronchial atresia and congenital pulmonary airway malformations. This is another lesion that just demonstrates the fact that there's a lot of overlap, both radiographically and histologically, particularly between bronchial atresia and sequestrations and congenital pulmonary airway malformations. So if you encounter a lesion that doesn't fit nicely into one category, use a generic term, congenital pulmonary malformation, describe the tracheobronchial tree, arterial supply, venous drainage, and precise anatomic localization, because that's what's going to matter if the patient's going to go to surgery. So just quickly, our question, CME question, a well-circumscribed rounded subcarinal mass is seen on a 26-year-old man's chest radiograph, suspicious for a bronchogenic cyst. What would be the most appropriate next step in evaluation if no prior exams exist for comparison? Non-contrast CT, T2-weighted MR, transesophageal ultrasound, or PET-CT? So, have the results. And the correct answer is T2-weighted MR. Again, it avoids confusion with proteinaceous or hemorrhagic lesions and avoids the use of ionizing radiation. Transesophageal ultrasound requires sedation, is usually reserved for intervention. PET-CT shouldn't be used for a benign lesion at the top of your differential diagnosis, and non-contrast CT can sometimes be confusing because of proteinaceous lesions. Thank you.